We'll move on to the next presentation by Dr. PIYUSH, who will be talking to us on the posterior segment manifestation of closed loop injury. Over to you, Dr. PIYUSH.
So patients with blunt trauma may look innocuous in the first look, but a careful and detailed history and fundus examination is necessary to rule out the collateral damage. So the first step is to rule out an occult open globe injury. So on the left, you see a patient who presented with a subconjunctival hemorrhage after trivial trauma. But what we see after dilatation, there's an intraocular foreign body behind. So this is a case of open globe injury and not just a blunt trauma. So let us understand the mechanics of blunt trauma to the eyeball. So when a direct impact happens, the maximum damage is at the point where the blow is received. Then a compression wave goes and transmitted through the intraocular fluid in all directions, leading to contracoup damage in the all planes. Then the reflected compression wave comes and strikes the posterior pole, leading to the damage at the posterior pole. And finally, the rebound compression wave forces and strike back anteriorly. So we all know about the 7 rings of trauma: the iris sphincter, the iris base leading to iridodialysis, anterior ciliary body leading to angle recession, ciliary body to the scleral spur leading to cyclodialysis cleft, the trabecular meshwork leading to trabecular meshwork tears, zonules leading to lens subluxation and dislocation, and finally the retina to the aura, which leads to retinal dialysis and retinal detachment. So what is the epidemiology? Rate of retinal involvement among eyes with closed globe injury is 34%, whereas rate of vitreous involvement and retinal involvement in closed globe injury is 22%. So we'll be discussing on the various manifestation. First is the vitreous hemorrhage. Vitreous hemorrhage will occur due to the damage of blood vessels of iris, ciliary body, retina, and choroid. It may vary from a little hemorrhage to completely obstructing the vitreous cavity. So it may be associated with retinal breaks. It may be associated with Terson syndrome. And incidence of Terson syndrome in patients with subarachnoid hemorrhage can be 10 to 50%. So management, we have to screen the periphery for the presence of retinal breaks, and the patient should be followed up till to complete 360 degree of aura is seen. In case retina is not seen, we have to perform serial B-scan ultrasonography to see and rule out the retinal detachment, optic nerve head avulsion, and vitreous incarceration. In case it's only a plain vitreous hemorrhage, we can observe for spontaneous resolution. But in some cases, we have to go for early vitrectomy. These will include the associated retinal detachment or a large retinal tear, non-resolving vitreous hemorrhage, ghost cell glaucoma, single-eyed patient, bilateral vitreous hemorrhage, or if it is associated with subretinal hemorrhage. Another one is the lens dislocation, in which we'll have to go for PPV and PPL, and IOL can be put in this stage or maybe in the next stage. Then the vitreous base avulsion. There's a bucket handle sign, that is a part of vitreous base is draped over the peripheral retina. The image I have borrowed from ASRS retinal image bank. The symptoms may be minimal. Per se, vitreous base avulsion will not cause RD, but the clinician should be looking for retinal dialysis, giant retinal tears, and angle recession. And there is no intervention, just the patient has to undergo a close follow-up to look for the presence of other pathologies. Then optic nerve head avulsion. There's a rupture of optic nerve head avulsion at the disc margin, maybe at the level of lamina cribrosa, without damaging optic sheath. So the postulated mechanism will include direct trauma to the globe, sudden marked IOP rise, or the shearing forces from the acute globe rotation. So it can be complete or it can be partial. So this is a case which we saw in optic nerve head avulsion. There's an excavation of optic nerve head area because of the retraction of optic nerve into its dural. B scan and CT scan and MRI may not be very helpful. Another complication can happen is the vascular occlusion. This is the same patient with optic nerve head avulsion, and we can see a retinal artery occlusion here. And as we can also see, the ciliary retinal artery has not till now filled, even till all the veins have been filled up. Another will be Berlin's edema. It is self-limited transient whitening at the level of deep sensory retina. So 9.4% of all the traumatic fundus changes will include Berlin's edema. It is a misnomer because there is no edema actually. There's a disruption of the photoreceptor outer segments. It may take hours to develop after the trauma. Posterior if it involves the posterior pole, we may see a cherry red spot at the fovea, which may make the CRAO. Histopathological studies on animal models show that there has been disruption of photoreceptor outer segment. There is no proven treatment. It can be of two types, retinal concussion and retinal contusion. Retinal concussion is the milder version, whereas the retinal contusion is worse and can lead to permanent pigmented scars and incomplete visual recovery. So this is a case of Berlin's edema in the chronic follow-up where we see the scarring as happening. Macular hole. Trauma will account for around 10% of all the macular holes. PVD is usually absent in these cases. The macular hole tends to be more eccentric, less circular than the idiopathic macular hole, as the horizontal diameter may be significantly longer than the vertical one. So this is a case of a macular hole followed up for about 2 months. The patient did not consent for surgery. So there is no consensus on the management. Some say there can be a spontaneous closure, especially if the patient is young, if it's a small hole and does not have a vitreous cuff. Late surgery lessens the chances of good anatomical and functional recovery. So this is a case that was operated by Dr. Naresh sir, and a good visual outcome and anatomical outcome was seen. Then is the choroidal rupture. Rupture of inner choroid, outer Brooks membrane and RP. The fortified collagenous sclera and the flexible retina is less likely to rupture. So the incidence is around 5 to 10% of the blunt trauma. So it can be of two types. One is direct and one is indirect. Direct choroidal rupture is uncommon and usually parallel to the aura at the direct site of impact. And indirect choroidal rupture are more common. Like here we see a choroidal rupture nasal to the optic disc. And majority of them although occur temporal to the disc and may involve the fovea. Like in this patient, it is crescent shape involving the fovea. And the indirect choroidal ruptures, patient with brittle Brooks membrane, especially in cases of angiod streaks, are more susceptible, and they are associated with intrachoroidal, subretinal and intraretinal hemorrhages. So there is a long-term risk of CNVM, especially if it is associated with old age, macular location, and greater length of the choroidal rupture. Treatment is anti-VEGF injections. So this is a choroidal rupture that happened at the fovea itself. Multiple choroidal ruptures, some in the periphery and some mostly temporal to the macula. So subretinal hemorrhage is another complication. There's a blood collection between the neurosensory retina and the RP. It is classified according to the size. Small subretinal hemorrhage will be less than 4 disc diameter. Medium will be more than 4 disc diameter, but it does not extend beyond the temporal vascular arcades. And massive will overspread the temporal vascular arcade. So photoreceptor damage can happen due to iron-related toxicity, impairment of diffusion of oxygen and nutrients. So there are 3 treatment options. One is the pneumatic displacement. Second is the intravitreal TPA injection with pneumatic displacement. And third is the subretinal injection of TPA along with pneumatic displacement. So this is a patient who presented 3 days after severe trauma with subretinal hemorrhage. We treated the patient with intravitreal 0.3 ml 100% SF6. And 3 months, the subretinal hemorrhage dispersed from the fovea. So this is the final OCT with a little bit of damage remaining. Then another severe complication is chororetinitis scleropatera. It is the rupture of choroid overlying Brooks membrane, RP, neurosensory retina, and happens secondary to a high velocity projectile which hits the globe but does not penetrate it. So this is a patient, 18-year-old patient who received trauma while playing gilli danda. What we see are 2 adjacent chororetinal tears anterior to the equator in the inferior quadrant with thin strip of retina between them. So the teared up retina was seen lying on the nasal part of the retina. And what happens in the long-term follow-up, it will completely get scarred. The management is controversial. Incidence of acute RD is low because of the scarring as well as the young patients. But late RD has been reported in 1/3 of the patient, and majority causes retinal breaks that happen at a different site. And visual prognosis will depend on the location of the scleropatera as well as status of the macular and optic nerve head. So retinal tears and RD can happen. What the basic pathology is, vitreous-based avulsion can lead to retinal dialysis as well as GRTs. Abnormal site of vitreoretinal adhesions can lead to hole. Coop injury can lead to full thickness necrosis, and sudden PVDs can lead to HSTs. So this is a case of GRT that happened post-trauma. The basic difference between a GRT and retinal dialysis, as we all know, GRT is not supported by the vitreous, so the retina tends to fall back on itself. And most common location of tears will be the inferior temporal quadrant because this is the most less protected quadrant. And management in case of tears, we can go ahead with laser or cryopexy. Retinal detachment associated with dialysis, we have to go for buckling. And those associated with GRT, we have to go for PPV. So always remember to record the baseline visual acuity for both the eyes, to document presence of or absence of RAPD, to examine the other eye for the presence of signs of trauma or other pre-existing diseases, and normal anterior segment or vision should not deter the clinician from performing dilated fundus examination. Thank you. I acknowledge Dr. Chitranjan Mishra for providing me the image.